with Dr. Bernard Siegel, clinical professor of medicine at Hodman Medical College and Hospital in Philadelphia.
Jody, how do you feel?
Fine.
Do you have any problems, any shortness of breath? Any chest pain? Do you run and play with the other children? But are you able to run and play with the other children? Does Mommy prevent you from playing? She does?
Yeah.
Mrs. Daly, what brings you to my office?
Well, Jody had a checkup at school, doctor, and they informed us that she has a murmur, a heart murmur. Well, her husband and I are very upset about it. Needless to say, she cannot go to the gym with the rest of the children. She can't play on the playground with them. And what kind of life can she have like this?
I fully understand. What has been told to you about her heart murmur?
That she does have a murmur and that she just is not permitted to play with any of the children.
And as you understand,
No
the murmur is significant. From your point of view, she is perfectly normal. She runs around without any shortness of breath.
No problems. Up
Nope.
and down the steps, everything.
She does not complain of any chest pain.
No.
She doesn't squat,
No.
and she hasn't had any fainting spells.
None.
Fine. Mrs. Daly, we've now come to recognize that most murmurs in young children are perfectly innocent. In other words, there's no evidence for any abnormality within the heart itself. If one were to do screening studies in preschool and school children, approximately 20 or 30% of all these children would have murmurs. And one of the reasons for these children having murmurs is that they are thin-chested, and a slight murmur may be heard over the chest wall. But again, may I emphasize that most of these murmurs are perfectly innocent. There are no holes in the heart. There are no structural abnormalities related to the valve itself. And now, Jody, would you come along with me and we can apply a stethoscope to your chest? You've seen this before. Now, in the bedside examination of a patient with a heart murmur, I think it's important, first of all, to inspect the chest and see if there are any abnormal pulsations. Also, to look at the carotid and the venous pulses in the neck, because these abnormalities of pulsation may be telltale signs of any abnormality. Happily, Jody's carotid and venous pulses in the neck are perfectly normal. One then palpates the chest. One feels for a left ventricle in this position. Jody's left ventricle is not palpable. One then feels for a right ventricle. The palm firmly placed along the lower sternal border in this direction, and in a right ventricular lift, there is a decided lift of the palm of the hand, and happily, Jody demonstrates no evidence whatsoever for both left or right ventricular enlargement. And I cannot feel a thrill. And then, using the stethoscope, Jody, you're not ticklish, are you? You are? One applies the stethoscope to the apex area, and one may hear the first and second sound. And then one hears along the third or fourth left interspace, in this position, a murmur, a short and soft systolic murmur. And we will play this murmur for you at this time. Let's all listen now to Jody's systolic murmur. And now let's place our stethoscope at the pulmonary area in the second left interspace and listen to splitting of the second heart sound, which is perfectly physiologic and normal. Listen to splitting of Jody's second sound. You will note that the splitting is wider on inspiration than it is on expiration, and it is not fixed, thus excluding a specific abnormality. Thank you so much, Jody. You've been a good girl. Thank you. This is a photocardiographic depiction on an innocent systolic murmur. Note the first sound. The second sound, which is split into two components, aortic and pulmonary components, wider on inspiration, becoming almost single on expiration. Expiration, single. Note the systolic murmur, which is short and soft, of regular frequency, musical type. This is an innocent systolic Now, in patients with organic disease, particularly aortic stenosis, the murmur is louder, rougher, and is heard best not at the pulmonary area and not at the left sternal edge or lower sternal border, but up here in the second and third right interspace in the aortic area. And this murmur radiates well into the neck vessels. There may be a thrill either at the aortic area or in the carotid pulses. The rate of rise of the carotid pulse is abnormal. And now let's listen to a patient with aortic valvular stenosis. Note that the murmur is loud, ejection mid-systolic type, crescendo decrescendo, and the murmur is grade 4/6. You will note that the murmur of aortic valvular stenosis is louder, longer, and there are telltale signs on palpation. The left ventricle is palpable. The carotid pulse shows a poor upstroke with a thrill in the carotid vessel. Now let's go back to the second sound at the pulmonary area and listen to a patient with atrial septal defect. This is a photocardiogram taken from a patient with an atrial septal defect. Again, note the abnormally wide splitting of the second sound throughout all phases of respiration, but there's little variation between both components of the second sound. It's abnormally wide and relatively fixed throughout all phases of respiration. The electrical healthy innocent murmur is normal. This is Jody's electrocardiogram. The limb leads 1, 2, and 3, AVR, VL, AVF, and the precordial leads V1, 2, 3, V4, V5, and V6. This is a perfectly normal electrocardiogram. In the patient with an atrial septal defect, one finds an RSR prime pattern in lead V1. So the conspicuous findings of an atrial defect and how it's differentiated from that of an innocent murmur are the following findings. 1, wide splitting of the second sound at the area which remains relatively throughout all phase respiration. 2, an abnormal electrocardiogram showing an RSR prime pattern in lead V1. The murmur, remember, in an atrial defect is louder than it is in an innocent systolic murmur. Now, another condition that should be differentiated from the innocent murmur is pulmonary valvular stenosis. This is a photocardiogram taken from a patient with pulmonary valvular stenosis. Note that the murmur is heard best at the PA, at the pulmonary area in the second left interspace. The murmur is louder, longer, actually spills over the second sound with a soft pulmonary valve closure. The splitting is abnormally wide throughout all phases of respiration, but there is some variation, so that this condition may be differentiated at the bedside from that of aortic valvular stenosis. Again, note that the murmur is long, rough, and generally grade 3 or 4 in intensity with a soft pulmonary valve closure. This is an electrocardiogram taken from a patient with pulmonary valvular stenosis. Please note the tall R wave in lead V1, V2, and perhaps in V3. This is suggestive of right ventricular hypertrophy of a moderate severe degree. This patient has pulmonary valvular stenosis with significant right ventricular hypertrophy. Now, allow me to show you the typical holosystolic murmur that one sees, one hears, in patients with a ventricular septal defect. Let's listen to a patient with a holosystolic murmur of a ventricular septal defect. Please note that murmur is long, longer than the short murmur that is innocent, starts with the first sound, occupies all of systole, and ends with the second sound. Likewise, the murmur of mitral regurgitation, which is generally heard best at the apex, at the mitral area, is also holosystolic, not crescendo decrescendo, not ejection type, but holosystolic or longer. Thus, this murmur is organic and not innocent. If the murmur is short and soft, it's probably innocent. If the murmur is long and holosystolic, It's related either to ventricular septal defect, mitral regurgitation, and infrequently tricuspid regurgitation. Now, another innocent murmur has been the supraclavicular arterial Brewing. This is a Brewing, a short, soft, pistol-shot murmur, heard best over the carotid pulsation, right here in the neck, and it sounds like this. Very short, very soft. Heard best at the carotid area, and as the stethoscope comes towards the aortic area, it tends to disappear. Now, another innocent murmur is the benign venous hum. Now, this is an important murmur to realize because it is sometimes badly differentiated from that of patent ductus arteriosus. Now, the benign venous hum represents increased velocity of flow through the jugular venous system. It is a continuous murmur, heard best at the bell of your stethoscope, applied up here in the supraclavicular area. When one then applies pressure above this stethoscope or obliterating venous return, then the murmur will disappear. In summary, it is important for physicians to differentiate the innocent systolic murmur from that of the organic murmur at the bedside. And it is possible, with inspection, palpation, and auscultation, to differentiate the innocent murmur from organic murmurs with a high degree of accuracy.
The Network for Continuing Medical Education has brought you The Innocent Heart Murmur in Children with Dr. Bernard Siegel, Professor of Medicine at Hahnemann Medical College and Hospital in Philadelphia. Pinpointing the syphilis cases in your practice. Next on NCME.